Maeve, I think we are ready to go.
Great, thank you very much. So welcome everybody. Morning in the Irish time zone, and we have East and Central Africa and East Indian Ocean, so different time zones there. Thank you very much to everybody for joining us. And so COVID partnership in the year of the International Healthcare Worker, certainly an excellent time to consider partnerships. And in this session, particularly considering partnerships, what has happened in partnerships with innovation and technology, how we've adapted to COVID, how our priorities might have changed, and then specifically if there's been shifts in power and how that is affecting existing partnerships. And perhaps the speakers might have comments on new partnerships at this time as well. I'm very pleased my name is Maeve Levanon. I'm an obstetrician gynecologist in the rural part of Ireland, in the west of Ireland. And I have a little bit of experience in traveling to East and Central Africa. I'm very happy this morning to welcome Melissa, Tafeze and Trish as our three speakers. If Melissa is ready, I will present her bio and then I'll hand over the screen to her. So Melissa Bingham is a quality and IPC consultant with the WHO and is working in Timor-Leste with the partnership of Macau SAR Health Bureau and Timor-Leste. She's on the ground during the COVID response, and her specialty is to improve quality care through infection prevention control and water sanitation and hygiene, which obviously is a key feature of the COVID response. And so I'd be very happy to hand over to Melissa and to hear her comments on the knowledge learned in partnership work over the past year. Thank you, Melissa.
Yeah, thank you so much, Maeve. Should I turn on my video or just go ahead and share my screen?
Would you like to try it, and let's see how the internet copes with that. If you try your video first and then share content and see if we can manage both.
Okay, great. Hi, everybody. Nice to be with you all today. And then I'll go ahead and try to share my screen now.
Thank you.
Sure. Okay, so can you see my screen?
Yes, we're in the slide outline view. If you want to go into full slide view. If not, it doesn't matter.
There we go.
Great, thank you, Melissa.
Okay, wonderful. Well, thank you. And it's lovely to be on this call. Good evening, good afternoon, and good morning to everybody. So I'm just going to take the next 10 minutes or so and just walk you through our experience with the twinning partnership between Macau Special Administrative Region and Timor-Leste. This partnership started in 2018 and just concluded this past December. So a robust part of it was in the middle of the COVID response. So very keen to share what we've learned through this experience. So just a quick overview. I just want to provide a bit of background on the model that we use. And the spirit of the partnership and the twinning partnership work is based upon improving quality. So by nature, this model is designed to allow for flexibility and adjustment along the way. These are two of our guidance documents on TPI. The first one is the partnership preparation package highlighting the TPI model. And the second one is the taking action document, which is grounded in quality improvement theory and in quality improvement models that help guide partnerships through the improvements that are chosen to be made. The TPI model is based on three overarching objectives. The first one is partnership, which focuses in on the relationship between the two partners, or three, or however many are involved. The second is improvement. So this is when partners come together to jointly decide on what priority areas they are going to look to improve within the partnership. The third objective is on spread, and this objective we actually start planning for at the beginning to understand how the lessons learned on the improvements being made are going to be spread horizontally to other health facilities, and then also vertically, so different levels of the health system. So if the improvement starts at the CHC level, how will that go to the district health level? And then how will that go to a secondary or tertiary level? Or it could be switched. And of course, the improvements could go down, starting from tertiary to primary healthcare level. And ultimately, we like to see the improvements that have been made on the grounds provide some sort of evidence base to help feed back into the Ministry of Health. We also follow a 6-step model, which you can see has the spirit of quality improvement included in each step. So just taking the basic PDSA, Plan, Do, Study, Act model, we recognize that this Plan, Do, Study, Act has to take place in each of the steps along the way. So as you can see on the screen, the first step is around partnership development. It's when the partners come together to decide that they want to make this arrangement. Second is a thorough needs assessment to really understand what the situation on the ground looks like in the country that needs to be improved. And the third is a gap analysis, which helps to uncover those priority areas that might be considered for the partnership. The fourth is the action planning. So this is when the partners really come to jointly decide what improvements need to take place.
Great. That solves the problem.
Step 5 is the
It just seems to be one additional speaker, and we'll just check all our microphones, make sure we're on mute apart from Melissa. Thank you.
Action, and that's where the improvements really start to take place. And then, of course, the 6th step, which is around evaluation. So just kind of honing in on this partnership experience, particularly over COVID, now that you have a bit of background on the way of working and the way the partnership model is set up. So this partnership had been focused in on building IPC programming and capacity at 3 health facilities in addition to the Ministry of Health. So these 3 health facilities included a tertiary, a secondary, and a primary health center. Before COVID came, this was the snapshot of the 4 agreed objectives that the partnership was going to undertake. So fortunately, the improvement areas was already grounded in something very applicable to the COVID response. But when it was being initially chosen, it was recognized that focusing in on IPC practice and then water, sanitation, and hygiene infrastructure was chosen as the priority because it's so fundamental to improving the quality of, the basic quality of care in health facilities. So what changed? Well, ordinarily, we would encourage partners to do exchange visits. And this is the way that they really help to foster the relationship and to ensure cultural understanding in the partnership, in a way to really build that sustainability and that trust in the longevity of the partnership that hopefully carries on between the 2-year formal agreement and all of our partnerships. But because of COVID, of course, these normal exchange visits could not happen. We managed to get one in 2019, but in solidarity, the partners had agreed to continue with these exchange visits virtually. So while we missed out on that face-to-face connection, what really came through was the determination and dedication to improving IPC. And we recognized this was vast on both sides. And it showed the solidarity between health workers to just support each other across the globe and do whatever they could. The second big benefit that came about was because we were able to redistribute some of the resources that had been originally planned for other activities. It allowed us to scale up these trainings, these virtual trainings, and then invite more health workers from across different municipalities. And it gave these colleagues opportunities to share lessons learned and experiences both on building IPC programs, but then also their experiences and needs and current gaps in COVID, which wasn't something that probably normally could have ever taken place. We were also able to disperse some of the resources and focus a bit on building up some of the training materials and really delve into comprehensive IPC program throughout the country. And so COVID allowed us to open up to other partners and reach out to other partners who are also looking to improve IPC and WASH, and unite and come together to combine the training materials and the trainings themselves so that all of the colleagues throughout Timor-Leste were actually receiving similar training, and it wasn't misaligned, and it was well coordinated, which has farther shown to just really make massive, outstanding improvements in IPC activities across Timor-Leste. And I just have to brag slightly about the country. We have in total only about 200, close to 250 cases of Timor. So they've done an excellent job at mitigating the spread of transmission here in Timor-Leste. Just the last big thing that we were also able to do was redistribute some of the resources to start collecting foundational data on infection prevention and control. You might have heard from my colleague Shams Syed mention something earlier today about the minimum standards for building IPC program, which is a WHO document that shows a comprehensive approach in how IPC programs can be built both at the facility and national level. What we were able to do was translate some of these materials and do capacity building workshops to not only capacitate these health workers in monitoring and auditing of their IPC programs, but we were also able to do comprehensive data on what gaps across Timor-Leste existed and feed that information to the Ministry of Health, which further helped them to feed into the COVID response and the immediate needs that were very evident during that time. So just to close on my last slide, just wanted to share two big takeaway messages. And I'm just sorry, the video is covering up my messages. So the first one was that choosing a simple, realistic starting point allowed us to quickly adjust and continue to make the improvements and have dedication to the partnership and still have these be effective. The second big thing was adapting approaches and utilizing existing tools and modify them when necessary. Because human resources are obviously so strapped for every country and everywhere, COVID was not the time to make new things, but instead build upon what's already available and what's already been working on the ground. So at that, I'll just leave you a link to the website for Twinning Partnerships for Improvement at WHO. And thank you very much for your time.
Melissa, thank you very much for this wonderful presentation with the context set out beautifully, and then the simple tools that were used during the scale up. If it's okay with you, we'll come back to questions after we've heard from the other two speakers. So thank you very much. So if Tafeze would like to turn on his video, and I'd be very pleased to welcome him to the workshop this morning, afternoon and evening, as we move now to Ethiopia. So I'd like to introduce Tafeze Tufa, who's the coordinator of the Hirsch Institute in Asella, associated with the RC University in Ethiopia. And their partner is the Heinrich Heine University in Düsseldorf. And Tafeze is a PhD candidate in medical microbiology, having completed his master's already, and is assistant professor at the Institute. I'm very happy to hand over the screen and to Tafeze's presentation. You're very welcome, Tafeze.
Okay, thank you very much. Just, I'm trying to share my slide.
So our host has given speaker control. Is it a laptop device or a tablet?
Yes.
Laptop.
It is.
So is there a share content under your more? No, you've been assigned as co-host just now. And so
It says preventing access to your screen.
Now our host is sharing for it, and if you'd like to go into full slide view, if you wish. Thank you very much, Tafeza. We look forward to hearing your talk.
Okay, good afternoon. My name is Tafeza. I'm happy to get this chance to present you responding to COVID pandemic, the challenge we faced, and also some experience we acquired. To go to the next slide. I'm happy to introduce our institute, which is the Research Institute of Tropical Medicine. This institute was established in Asella since 2013, just by collaborating with RC University and University of Düsseldorf. The director of this institute is now Professor Lude, and the deputy director, Dr. Fate. I and my colleague Yannick, we are coordinating locally from Asella. So if you want to know more about the institute and want to collaborate with us, please talk to Dr. Fate. Then directly I will go to my presentation. How can I go to the next slide? Okay. This is my talk outlines. I will say a few things as introduction and COVID impact on the local health system, as you see, and the data we produced at Asella, and the way to forward to keep our collaboration and the partnership. And also at the end, I will present the lesson learned from the COVID-19 pandemic. Okay, to say a few things about COVID situation from Ethiopia. This is a report from Ministry of Health on March 17. As you can see from this, the case is really increasing, because we now reporting about 1,704 cases daily, and just overall we have tested more than 2 million. Then out of these, we faced total days 2,592. So when we calculate the positivity rate, overall it is around 8%, and the mortality rate is 1.4. But right now the positivity rate is beyond 22.5%. This is what I already told you. As introduction, actually I'm from University Hospital, so our hospital is not treating COVID, but we are in charge to diagnose the case. So for this purpose, we have a district hospital, which is Bokoji, far from Asella Hospital, 40 kilometers away. And those moderate cases will link it to this hospital, and those moderate severe will transfer to Adama or Asella treatment center. So far we already linked 487 moderate patient cases. So out of these, 31 of them died. That means the local fatality rate is 6.4, just among those admitted. But those tests, when tested positive and mild or asymptomatic, we allow them to go home. This admission is only for moderate cases. When I came to the COVID impact on the local health system, the first one is about TB, because Ethiopia is one of endemic country to TB. TB diagnosis and the treatment was interrupted, especially at the first 2-3 months. We are following DOT program, direct observation treatment, so the patient feels TB positive patient feel to come to hospital to take the medication. As a solution, what we did, we allow them to take the drug with them for a week or 2 weeks. And also on HIV care treatment, it also interrupted at the beginning. For example, my student did surveillance. They found that 1/3 of the HIV positive participants, they felt as discriminated and they ignored since COVID pandemic, even though now a little bit improved. The other is the number of mothers coming to the hospital for ANC service was reduced, and also high rate of home delivery just happened during this COVID situation. This also right now a little bit improved. Other chronic diseases like diabetes mellitus also interrupted at the beginning. The other interrupted is family planning and immunization service. Just this also at the beginning, but right now it was improved. Just so as a solution, what we did, we have different projects and studies. We interrupt our study and the project and just more focused to COVID diagnosis. So as a solution, what we did, we changed our microbiology lab by proposing for the COVID testing. Due to this, our institute or our research lab could be one of the first COVID testing center in Ethiopia, which is just at that time for 10 million. Now, since the testing capacity is expanded, just we are in charge for around 6.5 million. Then we also developed a project focused to SARS-CoV-2 on prevention, diagnosis, and management. Next. So as I already told you, this is the first picture was our microbiology lab. This completely changed to, as you can see from the picture, to the extraction room for COVID testing. And now our lab seems this is where we run the PCR test. We also did screening of health professionals and the healthcare workers in the compound in the College of Health Science of Aris University. And also we screen when students back from lockdown to school. This is some intervention we did. So in general, the COVID impact on the local health system, there is a shortage or lack of resource like PPE, sensitization, and some of our staffs also acquired the disease, and high stigma and the discrimination related to this COVID, particularly to our foreign colleagues, and increase of morbidity and mortality due to other disease, and also at the beginning confusion where and how to manage COVID positive individuals, lack of sustainability, maintenance of laboratory machines and equipment, particularly focused to PCR or molecular technique. And we also couldn't get at the beginning, especially equipment needed for PCR like microcentrifuge, heat blocker, biosafety cabinet, and the PCR tubes. So we import most of them from abroad, and we also use the Rotagene real-time PCR machine, which actually bought for other study. Now exclusively we are using it for COVID testing. So we didn't buy a new machine, we used the existing one. And we have been also importing different materials and reagents from abroad, particularly from Germany. So what we did, we strict to the recommendation from Ministry of Health or from the national. So the test was done in 3 phases: phase 1, phase 2, and phase 3. Before starting, by discussing with our colleagues from Düsseldorf, we gave training for staff, develop protocols for PCR, importing materials, and also rearranging the lab for molecular test. This was done from February to April. Then we started testing at HITM at our lab after we certified by national. And at that time, just the test is focused to contact tracing, symptomatic patient and high-risk group. That means those who have contact with someone came from abroad. Then the intention of this is to prevent the dissemination or outbreaks. And then phase 2, which is from August to September, it is massive screening or community surveillance. At this time, the government want to know the prevalence of this COVID in the population. Then the phase 3 from October to until now, just the testing is changed, like symptomatic or close contact with a symptomatic patient, and the elective procedure. Every patient come to hospital should be screened for COVID first, and also sport clubs and prisoners based on requests from different institutions. Just next to Asella. Next. So when I come to the SARS-CoV test results from Asella, just to say a few things about it. As I said, we have started the testing in April. The case reported from Ethiopia on March 13, but we found the first case in Asella in June 22. So it is after 3 months reported from the country. I think this is since we did good things on prevention or transmission of the COVID, especially quarantine at Bole International Airport, and just what the government did at that time. Since then, more than 32,000 tests run or done in this HITM, Research Institute of Tropical Medicine Lab. Out of this, we report as positive 3,219. When we calculate the positivity rate, is almost 10%. When we just compare by sex, most of them male, about 69%, and 31% females. Next slide. Reason for testing among those positive, just 60% accounted or among suspected one, and the contact tracing just 26%, and for admission, as I told you, just all patients came to the hospital or for admission should be tested first, and the community surveillance, and also for certificate, because we also providing certificate for COVID for international travel as well for different sport clubs. When we compare the positivity test by age groups, as you can see from the table, almost 50% of those positive is age between 16 to 30. Then followed with the age between 30 to 45. Next slide, sorry. This is the testing trend, just total test trend and the positive results by months. As you see, the most achievement we did is almost near to 2,000 per month. It was October to November. this time is when most of the sample also referred to us, since some nearest diagnostic center like Adama Regional Lab was non-functional. That's why we achieved, and we achieved low testing in December, end of December, and the beginning of January, since our PCR machine existed. Next slide. This is monthly positivity test result trend of the region, the Oromia region. As you see, the most achievement was in August and September. This is during the community surveillance or mass screening. This is the testing labs performed in summary in Oromia region. As you see, RC University, HITM, among universities in the regions, we are the first. Really, I would like to thank our colleagues from Düsseldorf and also German partners, since we got sustainable support. Just even though our daily capacity is 72, but what we did is just make us the first university or testing center from the region. Next slide. Way forward, just to keep our partnership or collaboration. Now we just focus to COVID partnership project by developing two proposals or two projects. The first one is COVID Zero project. Just as some of you already know it, it is to assess the SARS-CoV-2 seroprevalency in representative population among blood donors in 6 sub-Saharan African countries, and also to analyze the viral variant, if there is any new variant, by sequencing. And the second is the Prevent COVID project. This focused to implementation and evaluation of prevention measures and investigation of transmission routes. So to say a few things about this Prevent COVID, just we group in as hygiene, diagnostic, and surveillance. Just the hygiene is right now, just people almost reducing using like hand wraps and a mask. So just we want to just make a surveillance, especially baseline assessment, and then intervention to see the follow-up. The other is diagnostic. We want to upgrade the diagnostic in type of test and the manpower, as well the quality. And the third one is surveillance. Just when the prevalence of this COVID increase in the community, in the population, there is high likelihood that animals also will be infected. So we are also interested to screen some animals and vectors. Okay, the lesson learned from this COVID-19 pandemic is, as you already know, improved hygiene compliance like mask utilization, hand wraps, hand washing, improved reporting system. Just now we are using the HSL tool for reporting. We are reporting daily, and also better understanding of communicable disease in the community, expansion of molecular or PCR testing services across the country, and the skilled professional could run the test. Example, we have now trained professionals around 18 who can run SARS-2 testing or molecular technique, experience to manage such emerging outbreak, develop the culture of online learning, teaching, and the launch conference. That's why now I'm presenting you from Asella, Ethiopia, and others join from different country and a different place. And also utilizing existing partnership achievements like infrastructures, training, and exchanging. In general, it is a new opportunity for partnership project. This is all what I have. Thank you.
Tafeza, thank you very much for your presentation, building on Melissa's. And particularly exciting to see how, from the diagnostic side, from the laboratory side, how you were able to switch to the new virus, and yet consider how you still deliver your programs for TB and HIV. Thank you very, very much, and we'll come back in the questions if we may. So we'll move on to, thank you, Tafeza. We'll move on to Dr. Trish Scanlon, who is joining us from Dar es Salaam. So from the high altitude of Asella, we'll move down to coastal climes on the Indian Ocean. Trish is an Irish paediatric oncologist and is CEO of the charity Tumaini La Maisha, Their Lives Matter. So she works in paediatric cancer services and is instrumental in nationally reducing mortality from cancer, paediatric cancer in Tanzania. She has won awards for her work in her university of origin, University College Dublin, and the Royal College of Physicians in Ireland. I'm very happy to hand over to Trish. I'm not sure if she wishes to share a video today or is happy to go with slides, whatever works best.
Thank you, Maeve. Can you see my slides?
Yes, we can see your slides.
Okay, perfect. Well, sure, I'll start with that. And thank you very much to be part of this session. I'm very grateful and I'm really interested in what the previous speakers have said, and congratulations to them. So I'm just going to briefly give you an idea of what it's like of running a service in the time of COVID, a clinical service. So for the last 15 or 16 years, I've been in Tanzania and working with the government and in the National Service for Children's Cancer, building it up. So obviously, I don't know if any of you know anything about children's cancer, but you know, things have there've been extraordinary developments since the 1940s until today, where in the 1940s, if you had a cancer, if you couldn't cut it out, you more or less died. Whereas today in Crumlin, for example, in the Children's Hospital there, about 85 to 90% of children are cured long-term from their disease. However, there is still an enormous gap between high-income countries and low and middle-income countries in survival. And one of the things that we've been trying to do over the last 15 years is change that gap. And we have had enormous success. We're nowhere near 85% survival yet, but we have made inroads in that. When we looked at the cases in 2005, we had a survival of less than 10%, and we had only about 120 children who came to the service. Whereas in 2020, despite coronavirus, we had over 700 children, we had 729 children who came to the service. And they were spread across 9 different centres, all of which are coordinated centrally, and our survival was approaching 50%. So we've made enormous progress. The other really wonderful thing about the programme is it is largely free. In Dar es Salaam, which is the hub of the service, everything is free, including surgery, chemotherapy, the stay, any blood tests, any radiology, including CT, MRI, all of that is free for the children. Some of our partner sites around the country do charge a little bit, but there's very little that is prohibitively expensive for families to cope with. So we've made enormous progress over the last 15 years. And these are the types of children who have come into us over the years. So you will just see that it is not that these are small diseases. These are children who have really extraordinary advanced disease when they come to us. But the chemotherapy that is provided, and the organization that I run, which is called Tumaini La Maisha in Kiswahili and Their Lives Matter in English, we pay for the chemotherapy for every child in the country. But as you can see, what looks like a desperate situation that is beyond hope actually can be pulled back from the edge quite quickly into a beautiful mischief-making child. And that is what we wanted to protect when this virus hit us all. So back in March of last year, we had to sit down and basically have a war cabinet about what we were going to do about this. One of the biggest things was what we were going to do in terms of funding all the necessary changes that needed to be made. Then we needed to change a number of routines around the ward. And we obviously then, even if we had the money, we needed to figure out where we were going to get the supplies that we needed. both in terms of consumables and also equipment that was required as a matter of urgency. So if we start with the costs, so we estimated that we needed to almost double our budget. And I'll go through why in a minute. But this was kind of one of the scariest things. How are we going to raise, 500,000 more than we had anticipated needing? So the first thing to say, and this is a summary of what we've done for the last year, is we were really overwhelmed by the support that we got. And as this is a partnership discussion, all of our partners stepped up. There was no partner that withdrew funding because we had to pause a program, or who, when approached and asked if there was any way they could help further, that they didn't actually help further. So we really, looking back a year later, we really are extraordinarily grateful to everybody who was involved in keeping us going and keeping the service doors wide open. And that included an awful lot of Irish partners. So Irish Aid, what they did was they didn't have extra money, but what they did was they closed the grant 6 months early and opened a new grant, which essentially gave us access to an extra 6 months of funding, which was enormously helpful. I, at one point in March, April and May, I was on radio or television or in the newspaper in Ireland quite regularly, just pleading with people, and there was a massive response. Esther also helped us, and then there was a number of other charities that supported us. And we also had a number of donors who we had not worked with before, who either approached us or we approached, and they were enormously helpful. And then finally, one of the great things about all of this was, despite all the chaos and despite all of the fear and what restrictions of movement and restrictions of work practices, we were able to continue to expand and grow what we were doing. And one of those things was in the area of research, and allowing very complex research to happen on the ward allowed us access some of the funds that then we used to help support the children. So just to go through the changes and what partnerships helped us. So obviously we had to change our routines. We had to stop all visitors to the ward. We had to do temperature checks. We had to teach everybody about social distancing. So we had lots of support, including from local graphic designer who did all sorts of beautiful posters for us. And the Muimbili team and the TLM team were amazing, and they all stepped in to support each other and help each other, and were very open to all the changes. So I think one of the wonderful lessons from all of this was, even though, and there were times when I would speak to staff and say, because this, at the very beginning, none of us knew how contagious this was and how ill any one of us might have become. So there was real fear on the ward, but there was also a real sense of solidarity and camaraderie. And I really, enjoyed going to work every day, even though we were all a bit frightened a year ago. The types of changes we made in the staff, well, we employed a few extra people so that we had more cleaners, we had more doctors, more nurses, so that we could then divide. We have 2 ward spaces. We were able to divide the staff into each ward so that there was no mixing. The junior doctors, who usually do call from home, which I never liked, we were able to convince to do call in-house, so that if anybody was sick, there was somebody who knew what to do on hand. We also said that people, because they were working harder and because it was more stressed, we had people on 4-day weeks instead of 5-day weeks, and that worked perfectly. And then the staff acting as gatekeepers, basically, we're watching each other and minding each other, so that if anyone was about to step into an unsafe situation, there was always people, pulling them back and making sure, have you got your mask on? Have you got your, I don't know, your apron or whatever? So it was much, rather than stay away from me, I'm afraid of you, it was much more, you there, you're in an unsafe situation, I want to help you. So that was the kind of atmosphere that was created on the ward, which I have to say was a really wonderful achievement by the entire team. We also said, because again, as we didn't know how bad it was, we suggested that 60-year-olds and above, if they had comorbidities, could work from home at that point. And we allowed anyone to work from home almost permanently, and we did not let anyone, nobody lost their job over all of this. And we also got everybody off public transport, and you probably have seen what buses look like in Africa, so it was really important. But half of that was the staff themselves organising and giving each other lifts and being in little teams and bubbles, and that really helped. Some of the restaurants around the city helped with food, and then a lot of our meetings went obviously by Zoom or Teams. So as you can see, our staff turned into Uber drivers for each other to get them off these incredibly overcrowded buses. And we had lots of deliveries of food, and that really increased the morale as well in the ward. One of the companies who's local decided to provide us an endless supply of hand sanitizer and bleach for the ward, and that obviously helped us as well because everyone was able to have it in their pocket at that point. The next thing was we realized, because we get almost all of our supplies from overseas, from India largely, and you know, the countries around the world were closing down and ports were far less busy than they'd ever been. And so we realized that we would run out of chemotherapy. We would run out of other things like gloves and syringes if we didn't act quickly. And so we had to stockpile all these things. Whatever was around in the city, we ordered and supply and basically took the stock of. And we also ordered to try and get stuff in as quickly as possible. And normally we don't have large amounts of money, so we do it in like 3-month batches. But we had to order large supplies to try and make sure that the children didn't go without. Another really wonderful initiative was that the kind of a community group in Dar es Salaam made up of all different backgrounds and, you know, international people and local people got together and made thousands of masks for us, which we then distributed across the hospital, and other things like you see the gowns there and the theatre caps and things. They made all sorts of things for us, and they provided it. So again, people who were at home and didn't know what else to do really did get a sense of community, which was a wonderful thing. And then we had some other pieces of equipment, and again, some of these we needed to buy, and some of them were supplied. A company called Malin had given us a UV sterilizer for rooms. This orange machine here that looks a bit like a machine from a Star Wars or something. It's something we were using intermittently, but we've now started using it twice a day, and it sterilizes every room in the ward and makes a big difference. And the other things we had to buy or modify. So for example, we had to put in new sinks, and we had to buy equipment in case the children or the parents got sick. And all of these, as I say, added to the costs of the program. And we were so grateful then that we had all these donors helping us do this, and really appreciating and understanding the kind of the fear and the urgency of the matter. So it really, really helped. So the other thing was, well, we had to continue our service. And what is amazing is we're now looking back a year later, and the number of children who came into us from 2019 to 2020 was largely unchanged. Now, normally we have about a 10 or 15% increase year on year, so possibly it is down a little bit, but it's not down by much because our 2019 and 2020 figures are pretty much the same. And we have continued to expand the network. So the network is basically, what we want to do is have no child in the country more than a 4-hour journey from the Children's Cancer Network. The blue star there is Dar es Salaam, and that's where it all began. The green stars then are the university hospitals around the country, and we hope that in time they will all become tertiary level hubs, which means that they can provide all cancer treatment to all children. And then the yellow ones are the second level sites. They can provide some cancer treatment to children. And then the purple ones they don't provide cancer treatment, but they suspect, stabilize and transfer, and they have easy access into any site that has the treatment the child needs. So we had 7 at the beginning of the year, and we have 9 now at the end of 2020. So we managed to continue to expand that, which I think is really amazing given the restrictions in terms of transport. And the children themselves can move around this network. So if a child starts, say up here in the northwest of the country, if I can move no, it's not moving that, there we go. And the child needs care in Dar es Salaam, well, we will send the money by mobile phone technology to the doctor in charge, who will then go and buy the bus ticket. The child will then come to Dar es Salaam, and we will take care of the child. And all of this is done at no charge to the families. But what was also interesting was we were able to expand other programs that we have that we've been working on for many years. This, for example, we've been working on for about 10 years, which is an electronic medical record system for pediatric oncology. It has taken us a long time to get to this point, but 2020 allowed us, because people were sort of stuck in wherever they were, we were able to spend a lot more time on programs and on projects that kind of needed extended sort of concentration. So this has now been completed, and we're about to launch it on the ward, and hopefully we'll expand it across the network. It will allow standardized collection of data. It's a really simple system, and yet it also uses all the international code, like as you see here, the ICDO for oncology, which is the coding system for diagnostics. So this will make a big difference, both in terms of just gathering data and then using that data, whether it be directing support for better treatment or, you know, informing donors of how we're doing. So, oh, sorry, there's a video with that. And then this is the second project that we were able to progress in the year. And this is basically what we found was originally we were using this sheet here to write chemo. And as you can see, there's a lot of white space, which means that all of these have to be handwritten and manually calculated in terms of dosing, in terms of what way it is prescribed, what route, what rate, and what diluent you use and what volume. All of those things someone has to know, either look it up or guess, and a lot of it was guesswork. So we found that that was very unsafe. So instead, what we started to do was make these Excel sheets. And as you can see, the only boxes that need to be filled in now by hand are these yellow sheets, these yellow boxes, and then everything else is automated. And the third step, which is the step we have been working on this year, is to make these Excel sheets into a formal online application. And this again is even safer because all of these cells, which are accessible to the user, but we don't want them to be because they could modify them and change them and therefore maybe make the Excel sheet into nonsense or something dangerous, are now inaccessible to the user. They just have access to, say, these yellow boxes, and that will allow them then to make the chemotherapy prescribing, and we would also be secure that they aren't making any changes they're not supposed to. So we've been able to make huge changes during COVID. And then the other thing we were able to restart was our pediatric oncology masters. So despite the fact that it was a difficult year for travel, we were able to put all of the training online, and we now have 3 fellows who are in this master's program who started in October to train in pediatric oncology locally in Dar es Salaam. So that's again another milestone that we're very proud of. And then finally, as I said, we've been involved in really exciting international research, which is actually groundbreaking. The AI Real study is basically looking at blood tests and checking for circulating free DNA, which has come from tumor cells that have broken down. And the idea is to look and see if a blood test of this DNA would be as effective as taking a biopsy. And if that was the case, that would turn a diagnostic timeline from several days up to a week or 2 sometimes to 2 to 3 hours. And it can be done locally in the lab. So that will make a huge difference. It has also been, the test has been created specifically for East Africa. So this is a research project which has been designed for Africa and will help East Africans and East African children specifically. So it's really important. The second one is a rituximab study. Rituximab is a monoclonal antibody, which is extremely expensive, even though it is routinely used in non-Hodgkin's lymphoma and some Hodgkin's kids across the world. But because of the price has been very, very kind of prohibitively expensive for African kids. What this study is looking at is if a smaller dose would have the same effect. And there's some lab evidence that the dose that's being suggested is too large. If it was smaller, then it would make it much easier for us to use it across the spectrum of diseases that need it. And then finally, in UCD, we have a program where we're just about to launch, which is really exciting, which is again looking at the genetics of leukemia children in East Africa. Again, this has never been done. There's been no published studies, despite the fact, again, that genetics often direct personalized treatments for leukemia children in Ireland and in most high-income countries. So this really needs to happen all over the world, including places like Tanzania. And the nice thing thing about this is once we have identified what the most common genetic mutations are in children's cancer, children's leukemia in Tanzania, we will then be able to go back to the liquid knife group, this group here, the AI Real group, and they will make us a bedside test. So this isn't just a snapshot and a picture of what's happening in this particular group of kids, but it will lead to a diagnostic test that will be possible to use and get rapid access to the data for these children. So really exciting times, despite the fact that we have been saddled with this awful disease, COVID-19. So that is my talk. If there's any questions, I'd be happy to take them.
Trish, thank you very, very much for your presentation. Remarkable how the service has grown and developed during a year that has been a major challenge around the world. So if I could ask, we only have a couple of minutes left, if I could ask the three speakers if they can put on their video and they can open their mics. And I don't see any particular questions coming up in the chat, if anybody would like to put a question in the chat. And I might kick off with one question, if that's okay, that I'm quite keen to get the opinions from Melissa, Tafeza and Trish. It's the one about the power shift in the partnership. So we've heard how innovation has brought us along in testing human resources and scaling up. We've heard about the adaptation and we've heard about the prioritization. Could I ask the three speakers to comment on, did they perceive a power shift in their partnership? If they did, how or why did that happen? What was the learning from it? So first component, did you perceive that there was a power shift, or was the power already there in the countries in which you are working?
Yeah, I can take a quick stab at that question. I think it's an excellent question, and I think, you know, this whole idea around energy balance, just in general, both individually, but then also collectively, is something that really needs to be addressed and maintained, especially when, you know, as partners or people on the ground are overseeing the improvements that need to carry forth and ways to charge the momentum. And of course, leadership is so critical in that. I found in our experience, the power shift, it withdrew from both partners, really. People were scared. People were scared. People didn't know how to contribute. People just needed guidance and direction, I think, on both sides. And you know, we're particularly working in fragile settings. You know, I would have to say that at the beginning, it was very withdrawn, but then I would say maybe about 6 to 7 months in, the power shift in the leadership became very apparent, which was really exciting. And we as an organization had to, you know, we supported, but it was clear that they had oversight and direction on how they needed the infection prevention and control to work. And particularly after being able to provide, you know, data sets to them, it was very clear that, that they were in leadership over this. So I'll stop there and see maybe other people have different perspectives on this question.
Thank you, Melissa. Would Tafeza or Trish like to comment?
Yeah, I'll just very briefly say that, yes, things definitely changed. I think we had always had a model of, you know, if there was a gap, that we would find a way of fixing it anyway, and then try and make, you know, help it come back to Tanzania. So for example, in our pathology service, we had relied enormously on Crumlin pathology. In fact, Crumlin Hospital did all the pathology for many years for the children's cancer. In fact, they were seeing more pathology of Tanzanian children than of Irish children, even though they're the national hub for Ireland. But this year really rapidly changed. You know, we were heading in that direction, but that had to happen much faster, just because of access issues, but also because Tanzanians were stepping up and really like, we've got this. And so what we have done now is, you know, it all goes locally now, but there is a video link up and they can send slides by video and have conferences. So that was one of the biggest things I found is those kind of supports and technology things were changing.
Great. And I think Tafeza wanted to come in there as well.
Yes, at the beginning especially there was a power shift because others chronic disease ignored and are more focused to just COVID. So really from the government, also from the clinicians, even from the community, just there is a shift to only focus to COVID, and died many patients due to non-communicable disease or chronic disease. So like as I present TB, HIV, immunization, antenatal care service, and even home delivery, because people fear to come to, and also just health professional doctors also fear just because since it is new emerging disease, sure there was power shifting, but slowly we are now integrating the COVID and the other cases. Thank you.
Thank you. So there's a question in the chat room from Stephen Bodis. Do the three speakers see common challenges for their three projects? Worthwhile a coordinating effort is the question. So back to the three, and we're running into break time. If we can, we'll get on to the next question as well. So just a short comment on this one. Are there common challenges that are worthwhile a coordinating effort?
I think it's hard to comment because unfortunately we've only just heard each other's speeches and talks. Obviously there are common challenges, obviously, and always we welcome partnerships. And I certainly am very impressed with what the other two speakers have achieved over the last year. So yeah, I mean, it would be great to be in touch long term. I'm really sorry that's not it's not a very detailed answer.
I'll maybe just chime in, but I think it's a really good answer because it made me think. I mean, I think in general, behavior change and whatever practice that you're doing, whether it's more clinically focused or more IPC practice focused or what have you, behavior change always seems to be the hardest thing, and particularly during times of COVID when everybody's scared. If you don't hit people at that right time, behavior change just becomes a really, really tough issue. But very generic answer without the specifics of the other projects.
Would Tafeza like to contribute there?
Yes, I think we share all maybe similar because it is the diseases are just pandemic and the new. Maybe the difference is how we maybe respond and solve the challenge could be different, but I hope we all share a common problem.
Thank you. And we will go into a panel discussion of all the panels, so we might see more commonality when we go back into the plenary room at 11:15. And then just one final question before we wrap the session up. Have you any answers in terms of dealing with the stigma associated with COVID? Perhaps it's been seen as a foreign disease. So any comments on stigma in COVID care?
Well, it's been an interesting challenge in Tanzania. I'm not going to say very much about it, but what we did was we just got on with the changes without making a big deal out of it. And sometimes we didn't mention COVID, but got on it in terms of talking about infectious diseases and best practice for keeping people safe. And that was how we managed it.
Tafeza?
Yes, we really faced the stigma at the beginning, especially with we have German clinicians here, 2 German clinicians, and also many foreigners. So just people thought that it is related with someone came from abroad, the disease. So there is a big stigma, and also if it is the case reported from private hospital, private clinic, even hospital, if they hear no one want to go there. So it has really big stigma at the beginning, but slowly now reducing.
Thank you.
Yeah, maybe just quickly, I think the situation is quite the same. Lots of stigma, but I think both organizationally speaking, but then also just as a foreigner, I think, just intentionally with the ministry in what the health authorities in the country say, always wearing a mask, always being respectful of whatever rules are being set out. That's all we can do. And as it was said before, just push forward and, just recognize that that kind of comes with the territory and working in a country that's not your own.
So thank you very much. And thank you, Myron, for that last question. So I think we'll wrap up the session at this time. And so we have, I think, 7 minutes before our next session. May I thank again Melissa and Timor-Leste for their contribution, and Tafeza from Asella on his contribution, and Trish from Muhimbili on her contribution. It was a pleasure listening to all your talks and learning from the three of you. Thank you very, very much. And I hope you enjoy the rest of the meeting.
Thank you. Bye-bye.
Thank
Thank
you.
you.
Bye-bye.
Bye-bye.